Welcome everybody to the second part of the Peripheral Nerve ACNS webinar. Today we have three speakers, Prof. Sevline Estehtia from Indonesia, Dr. Egor from Russia, and Prof. Federico from Italy. And we have chairs by Professor Deborah Garosa, Professor 𝐏𝐞𝐫𝐢𝐩𝐡𝐞𝐫, Prof. Lucas Raslich, and Professor 𝐏𝐿𝐻𝐞𝐫𝐢𝐩𝐡𝐞𝐫 from Russia. Sorry about that. So we'll start with a few opening remarks from our Honorable President, Professor 𝐬𝐭𝐫𝐴𝐻𝐿.
Oh, hi everyone. So I'm very happy to receive the second webinar. And also today I understood one female neurosurgeon from Indonesia. I'm so happy. As a peripheral nerve is a kind of the good for the female doctors, I think. So today we have a very nice three topics. Very much looking forward to have your lectures. Thank you very much. Thank you, Deborah.
Over to Prof. Deborah.
Yes, thank you so much, Professor 𝐏𝐿𝐻𝐞𝐫. It's always, first of all, I have to say that we are here thanks to your enlightened vision, because it was your decision to set up a peripheral nerve surgery committee in the ACNS. So we are immensely grateful for that once again. I think we all believe that there is a need to try to implement peripheral nerve surgery as much as possible and to integrate it in neurosurgery. And we consider that this course, this online course, is going to be an excellent opportunity, a platform to provide education, but also to create a network and to see who in the world may be interested to join us on board in this adventure of improving the state of art of neurosurgery around the world. I would like to say that today the people presenting in this webinar are particularly dear to me. It's my immense pleasure to introduce Professor 𝐧𝐞𝐫𝐢𝐡𝐞, who is doing an amazing work in Thailand, and I would say both in ACNS and the WFNS. His commitment and dedication has been incredible, and is definitely an enormous asset for the development of peripheral nerve surgery. At the same time, I have to say that I am absolutely delighted to have a speaker, Dr. Sevline Estehtia, because she has shown a deep interest in peripheral nerve surgery that started many years ago. I had the privilege of meeting her in Belgrade several years ago, and since then she has always been regular in trying to improve the development of this subspecialty in Indonesia. And then, because as I said, one of the things that we hope to do with this kind of webinars is also that we want to discover new talents and new friends. And I was absolutely delighted when I went to Siberia in February last year, and I had the possibility to dig out of Siberia two precious gems, who are Dr. Bulat Kinziagulov and Dr. Egor Anisimov, who are being pioneers. I would call them almost trailblazers of this subspecialty in Russia. And although and I do hope they don't take it in the wrong way, although they are young, I think they have already shown that they have developed a lot of experience and expertise. So I think now it's time that we start with the webinar, and if my friend Jake is also agrees, I think we may give the word to Dr. Sevline, but I would like Professor 𝐧𝐞𝐫𝐢𝐡𝐞 to give a few words as well.
Okay. Hello everyone. Thank you for having me in this webinar and the ACNS Peripheral Nerve Committee. Thank you for your kind word, Deborah. Everything I do is just because of my love. I love peripheral nerve surgery, and I think everyone here love peripheral nerve surgery too. It's kind of gathering of people who speaking the same language. So thank you. That's all my word. Let's begin with the session today. Okay. So Sevline, could you share your slide? Okay, let me introduce Dr. Sevline, Professor Sevline Estehtia. She is my friend from Indonesia. Actually, she do a lot of spine surgery. Even though she is a female neurosurgeon, but she do a lot of spine surgery. But she also have, immense interest in peripheral nerve surgery too. I'm sure she is a rising star in peripheral nerve surgery in our region for sure in next few years. Okay. So she will give us a lecture on the anatomy of the lumbosacral plexus. So, Dr. Sevline, please.
Thank you so much, Prof. Ika, for the kind words and introduction. Congratulations, Dr. Deborah, for all your hard work. Thank you, Prof. 𝐏𝐞𝐫𝐢𝐻𝐿, Prof. Raja, and everyone. I will start with the anatomy of lumbosacral plexus. As like what Prof. Ika said, I mostly do the spine surgeries, but in my practice for the years, we cannot separate between the peripheral nerve and spine surgeries, and learning peripheral nerve completes my practice as the spine surgeon every day. So the disclaimer, all the pictures, because this is about anatomy, they are not my personal own, they are taken from the literatures and internet for the educational purpose only. So if we talk about the lumbosacral plexus, it is formed by the ventral rami of the lumbar and sacral nerves from the L1 through the S4, like you can see here. From the L1 to L4, it is a lumbar plexus, and then it is connected with the lumbosacral trunk from the L4 and L5, and then it continues from the L5 to the S4 as the sacral plexus. And we say all of this is the lumbosacral plexus. The lumbar part is formed by roots from T12 to L4. Some books said it started from the T12, some books said it started from the L1, and the sacral component by L4 to S4 roots. This divide into anterior and posterior divisions, which give rise to anterior and posterior branches respectively. The roots of the lumbar plexus lie on the ventral surface of the posterior abdominal wall, proceeding in diagonal fashion anterolaterally between fibers of the psoas and iliacus muscle. So if we talk about the lumbar plexus, we cannot forget about the anatomy of the posterior abdominal wall. As you see here, it's the psoas muscle, quadratus lumborum, iliacus, psoas major, and the rostral part, there's a diaphragm. So lumbar plexus, as you can see here, the position of the lumbar plexus is at the posterior abdominal wall once again. As soon as it comes out from the T12 until L4 spinal nerve, leaving the vertebral foramina here, it will connect and interdigitate one and another until become the distal branches. And we can see here medial to the psoas muscle, there's a lumbar splanchnic nerves that act as the preganglionic sympathetic fibers to control involuntary visceral functions, not to be confused with the lumbar plexus here, because the lumbar plexus is the somatic nervous system to controls the voluntary movement and sensation of the lower abdominal and wall and the lower limb. So the relation with the psoas muscle, if we can see here, it is emerged from the lateral border is the branch such as the iliohypogastric nerve, ilioinguinal nerve, lateral femoral cutaneous nerve, and the femoral nerve. And it emerges from the psoas muscle anteriorly through the psoas muscle is the genitofemoral nerve here. And from the medial border, we can see here, there's the obturator nerve. It's the relation with the psoas muscle. So if we see here, the subcostal nerve is the first branch originated from the T12. It is the last intercostal nerve that runs to the lateral and the anterior abdominal muscles and interfaces those muscles. And then we have from the L1 will comes out as the two branches here, the iliohypogastric nerve and the ilioinguinal nerve. The iliohypogastric nerve received contribution a little from the T12, and the ilioinguinal nerve is primary from L1. So these two nerves will run parallel to each other behind the kidney and in front of the quadratus lumborum muscle. And we will see the difference later because the iliohypogastric nerve doesn't go below the inguinal ligaments like the ilioinguinal nerve. And then we have the genitofemoral nerve here that originates from the L1 and L2 that responsible for both sensory and motor components of the cremaster reflex. We will talk about it later. And then from L2 and L3 spinal nerve will give branch to the lateral femoral cutaneous nerve that has no motor innervation as it named. From the L2-4 anterior division of the ventral rami will give branch as the obturator nerve here, while the L2-3-4 posterior division of the ventral rami will give branch as the femoral nerve here. Okay, so now we are going to talk about the iliohypogastric nerve. It is from the ventral primary rami of the T12 and L1 spinal nerve. It emerges from the psoas major and travels between the quadratus lumborum and kidney to the iliac crest, and then later pierces the transversus abdominis and then divides into two cutaneous branch, lateral and the anterior. And the motor innervation supplies the internal oblique and the transversus abdominis muscle. And the cutaneous branch will end up in the superior of pubic bone and give the sensory innervation of the lateral gluteal region via the lateral cutaneous nerve and suprapubic region via the anterior cutaneous branch, and sometimes it is called the suprapubic nerve for this iliohypogastric nerve because this anterior cutaneous branch innervation at the suprapubic area. And then we move to ilioinguinal nerve from the ventral primary rami of the L1. The course actually is parallel to the iliohypogastric nerve, but it emerges from the psoas major and then course to the iliac crest to pierce the transverse abdominis muscle. But from there, it travels through the deep inguinal ring below into the spermatic cord in male and round ligament in female. And the motor innervation, it will supply the internal oblique and transverse abdominis muscle like the iliohypogastric nerve, but the sensory innervation will supply the skin sensation of the upper anteromedial aspect of the thigh and parts of the external genitalia, which is the anterior part of the scrotum and anterior part of the labia. Because of this, sometimes this nerve is called with the anterior scrotal nerve or anterior labia nerve. And then we move to the genitofemoral nerve. This is from the L1 and L2. It is responsible for both sensory and motor components of the cremasteric reflex. So it travels within the psoas major muscle and emerges on the anterior surface of the psoas, as I showed you before, where then it divides into the genital and the femoral branch. The genital branch, it is the motor function in nature, and it travels within the spermatic cord, and the femoral branch as the sensory function travels to the area of the savannous opening. So the motor innervation of this nerve supplies only one muscle known as the cremaster muscle by its genital branch. So in a female, the genitofemoral nerve has no functionally motor component. It is sensory only in female. And the cutaneous sensations comes from the superior medial aspect of the thigh or the femoral triangle. So hereby the distribution pain that comes from the iliohypogastric nerve, ilioinguinal, and the genitofemoral nerve, because this is those are the complex of the inguinal nerve. And then we move to the lateral femoral cutaneous nerve, the other branch of the lumbar plexus, composed by the posterior division of the L2-3 spinal nerves. It emerges from the lateral border of the psoas major and passes inferolateral across the iliacus muscle under the inguinal ligament and then enter the thigh behind lateral end of the inguinal ligament near anterior superior iliac spine to the sartorius muscle, branches to the anterior branch and the posterior branch. So as it named here, this nerve has no motor innervation. And the cutaneous sensation are brought from the anterolateral part of the thigh. We will see it later. So if there is compression of the nerve at the inguinal ligament, as you see here, as along the course of the nerve, the pain distributions are shown in the picture, in this picture, as the neuralgia paresthetica, and this nerve is at risk when we perform the procedure like the harvesting of the iliac crest during several spine surgery. And then we move to the obturator nerve. Obturator nerve is from the anterior division of the ventral rami of L2 and L4 spinal nerves. It descends through the psoas major and emerges medially near the pelvic brim. As you see here, it is medial. And then it then travels through the obturator canal and divides into anterior and posterior branches. We need to review that the medial of the psoas major muscles, the medial from the psoas major runs the obturator nerve, and lateral from the psoas is the femoral nerve. So obturator nerve runs through the obturator foramen and supplies primarily the adductor muscles. It is the primary nerve supplying the adductor compartment of the thigh with motor innervation to the obturator externus, adductor longus, brevis, adductor magnus, gracilis, and pectineus. And the sensory innervation brought from the medial part of the thigh by the cutaneous branch of the subsartorial plexus. And it supplies both knee and hip joints. So these are the muscle that innervated by the obturator nerve with the function and the innervation. You can see here, it is mostly for the adduction. And now we move to the femoral nerve, originated from the posterior division of the ventral rami of L2, 3, 4. If the obturator nerve is from the anterior division, so the femoral nerve is the posterior division. Actually, this is the largest branch of the lumbar plexus. We can see here. There's 2 branches here. Sometimes 3 to innervates the iliac muscle in the pelvic directly with, which is this muscle is at the posterolateral side of the nerve from the previous picture. The femoral nerve runs below the inguinal ligament, and we can see here the position of the femoral nerve. It runs below the inguinal ligament, and we can see the position towards the femoral head. So if there is a anterior dislocation of the femoral head, the femoral nerve is at risk to be injured here. So motor innervation, it supplies many muscles, including psoas major, iliacus, and the complex of it. We call it iliopsoas, pectineus, sartorius, rectus femoris, vastus lateralis, vastus medialis, and vastus intermedius, the quadriceps. And for the sensory innervation, it gives rise to the medial femoral cutaneous nerve from the medial thigh and an intermediate cutaneous nerve. And it also gives rise to a very long cutaneous nerve, the longest nerve, the saphenous nerve, for the medial knee, medial lower leg, medial malleolus, and arc of the foot. And it supplies both the hip joint and knee joints too. So this is the distribution of the sensory innervation of the femoral nerve. So, and this table shows the motor innervation of the femoral nerve, like the muscle iliopsoas, the quadriceps, sartorius, and pectineus, with all the function of the muscle. So this is just the example from the Alan Maneker book about the anterolateral exposure of femoral nerve, because of all my talk is more about the schematic drawing. So I suggest to open the surgical atlas if we want to implement the anatomy schematic with the surgical anatomy, because it's quite very different. So this just the example of anatomical exposure of femoral nerve from the anterolateral approach. So after the fascia lata and iliacus fascia is open and sartorius muscle has been retracted, these are the configuration of the femoral nerve that is lateral from the femoral artery. This nerve is at risk too for the procedure like the catheterization. And this is the position of the nerve below the inguinal ligament. So this is the summary, just a short summary about the femoral nerve and obturator nerve as the part of the lumbar plexus, the distribution of the sensory innervation, and then the muscle for the motor innervation. Now we're going to move to the sacral plexus. So basically it is formed by the ventral rami of the L4 to S4 spinal nerve. The lumbosacral trunk, as you see here, composed of the L4 and L5 contributions to the sacral plexus. It passes medial to obturator nerve into lesser pelvis where it joins the sacral plexus. So from the previous lumbar plexus, it is the only spinal nerve that get into the pelvis, this lumbosacral trunk, because it will join the sciatic nerve to form the plexus. So at the sacral plexus, sciatic nerve is the predominant output of the sacral plexus, being made of axons from the L4 to S3 spinal nerve, as we can review it again. But, there are some branches here starting from the proximal formation, not only the sciatic nerve. If we talk about the sacral plexus, there is the superior gluteal nerve. It made up from the L4, L5, S1, and then inferior gluteal nerve made from L5 until S2. And then sciatic, we already know, L4 to S3. And then posterior femoral cutaneous nerve from S1 to S3. And the pudendal nerve from S2 to S4. Actually, the branch will come from the 3 nerve roots, if you can see the pattern, except the sciatic nerve. And if we put in order, the branches will have the arrangement where the following nerve root will start with the lower numbered root than the previous one. As I told you, inferior gluteal will start from the L5, S1, and S2 because the superior L4, L1, L4, L5, S1. It's just my own way to remember. So the sciatic nerve exits the pelvis via the greater sciatic foramen inferior to the piriformis muscle here, as you can see here. And then the nerve moves laterally in an oblique direction beneath the gluteus maximus that is retracted here toward the midline of the posterior aspect of the leg. And at this level, it runs above the 5 bed of the muscle, as 3 of them are shown here, the superior gemmelli, obturator internus, and then inferior gemmelli, quadratus femoris, and then adductor magnus. On its medial side, it's accompanied by the posterior cutaneous nerve of the thigh and the inferior gluteal artery, not shown here. So this is just again an example from the Alan Maneker, because sometimes we need to always open the atlas. So incision follows the lateral aspect here of the buttocks parallelly along the gluteal crease and then inferior along the midline of the thigh. As I stated before, that the sciatic nerve run in the midline of the thigh. So we need to find the inferior edge of the gluteus maximus here and the beginning of the long head of biceps femoris to perform our dissection. And then we can find the sciatic nerve. This exposure is really useful if there is injury of the sciatic nerve, like a gunshot wound or the sharp lacerations of the sciatic nerve. So the nerve descends in the thigh close to the midline, lying to adductor magnus, as you can see here, and being crossed obliquely by the long head of the biceps femoris muscle. And then the nerve divides into the tibial nerve and then the common peroneal nerve, common fibular nerve at the 1/3 distal of the thigh. So tibial nerve and the common peroneal nerve, common fibular nerve. Tibial nerve is more medial and larger. The common peroneal nerve is lateral and smaller. Those are the differences because sometimes we need to know the difference. Where is the position of the tibial nerve? Where is the position of the common peroneal nerve? Not only for the exposure, but if we perform the repair and we want to do the reconstruction of the sciatic nerve, and we have to choose between the tibial nerve, common peroneal nerve, we have to know the position of the nerve. So the tibial nerve composed by the anterior division, but in contrast, it innervates not the anterior part, but the posterior compartment of the muscle. The same with the common peroneal nerve, it composed by the posterior division and innervates the anterior compartment of the muscle. So the sciatic nerve is very big and very complex with so many muscle, and we can see here the innervation and the motor branch from the buttock and the thigh. This is still as unification from the tibial nerve and the common peroneal nerve. So the tibial part will give branch to the semitendinosus, semimembranosus, long head bicep femoris, and adductor magnus, hamstring muscles. And then you can see the common peroneal nerve will give a branch to the short head of bicep femoris. The long head is from the tibial nerve. So descend to the lower leg. I forgot to put the position of this nerve at the popliteal fossa. Tibial nerve innervates the posterior compartment muscles of the lower leg for plantar flexion, foot inversion, and toe flexion. It gives branch to the gastrocnemius, soleus, tibialis posterior, flexor digitorum longus, and flexor hallucis longus. The examinations are very important, so we can localize the lesion and where is the pathology, especially in the case of the foot drop. Deep peroneal nerve group innervates the anterior compartment muscles of the lower leg for dorsiflexor of the foot. So all the sciatic, tibial, and the peroneal nerve, we need to learn the motor function, the sensory function, because the lesion of this nerve is mimicking the radiculopathy 2 from the lumbar, and we need to know how to differentiate the level of the pathology. So the deep peroneal nerve give branch to the tibialis anterior, extensor digitorum longus, and extensor hallucis longus for the dorsiflexor of the foot. And then at the lower leg, the superficial peroneal nerve mediates foot eversion by innervating the peroneus longus and peroneus brevis, as you can see here from the Russell book. At the foot, the motor innervation from the dorsal tibial nerve motor innervation, it gives a branch to those muscle, abductor hallucis, flexor digitorum brevis, hallucis brevis, and first lumbricals of the foot. And lateral plantar nerve group innervate most of the intrinsic muscles of the foot. This lateral plantar nerve group analog with the ulnar nerve at the upper limb. So this is the picture of the branch. And at the foot, from the deep peroneal nerve group, only give branch to the extensor digitorum brevis. So this is the schematic drawing, just to remember. If we are the neurosurgeon in practice wants to learn a peripheral nerve, sometimes in the schematic drawing help us to remember and then review again about the branch and the function of the nerves and the cutaneous branch too. These are from the sciatic nerve, the tibial part, and this schematic drawing is from the common peroneal nerve. So we can see at the different level of pelvis, gluteal, thigh, lower leg until the foot. So this is the sense innervation of the sensory of the, if we join the lumbosacral plexus, all the branch of the lumbosacral plexus in the lower limb. So as I stated before, the sacral plexus is not only the sciatic nerve. We have the superior gluteal nerve made from the axons from L4 to S1. It leaves the pelvis via the greater sciatic foramen. No sensory branch. It gives innervation to two muscle, which is gluteus medius and minimus. And with the function abduction and the internal rotation and external rotation, and for the gluteus minimus, it's internal rotation of the thigh, both innervated by the superior gluteal nerve. And then we move to the distal part, the inferior gluteal nerve made from L5 to S2. Again, this has no sensory innervation. It innervates the muscle of the gluteus maximus for the retroversion and external rotation, abduction and adduction of the leg. And then the posterior femoral cutaneous nerve from S1 to S3, as the name. It leaves the pelvis via the greater sciatic foramen, entering the gluteal region inferiorly to the piriformis muscle. It descends deep to the gluteus maximus, runs down to the back of the thigh to the knee. Innervates the skin of the posterior surface of the thigh and leg. Also innervates the skin of the perineum in a small part. And then the last one is the pudendal nerve from the S2 to S4. Actually, it's primarily originates from the S4, but with supplemental input from the anterior division, both from S2 and S3 nerve. It has the motor function and the sensory function too. The motor function innervates the skeletal muscles in the perineum, external urethral sphincter, the external anal sphincter, and levator ani. With the branch inferior rectal nerve, there are three branches of the pudendal nerve, perineal nerve, and the dorsal nerve to the penis and clitoris. So those are my references. That's the review from the anatomy. I really thank you to all my teachers and my mentors that inspire me to learn and learn every day. And we invite everyone, if you have time, to come to Indonesia. Thank you so much.
Thank you so much, Dr. Sevline. I think this was a truly excellent, very clear, very, very detailed anatomical lecture. I really enjoyed it. I thank you for your effort, especially because the anatomy of the plexus, both talking about the brachial plexus that was mastered last time perfectly by Dr. Bulat Kinesiagulov, and also this time by you talking about the lumbosacral plexus, is not easy. It's quite challenging. So thank you so much for providing this very comprehensive talk. I think we might proceed with the next speaker. Ika, if you want to introduce the second speaker as well, please.
Okay. Let me introduce Professor Egor Anisimov. Can you share your slide? Professor Egor is from Russia. So he speaks to us the anatomy of the nerve branching to the from the lumbosacral plexus. Okay.
Hello, everyone. Thank you so much the chance to have my report. The previous speaker did a great job and covered almost everything.
I'm sure, Egor, that you can add new information to that. Don't be modest. We know that you are going to surprise everyone. So please go ahead.
Thank you. I will try to. So we will discuss about the anatomy of the nerve branching off from the lumbosacral plexus. So the large number of branches, we know that, and we will talk about a few of them. One of them is the lateral femoral cutaneous nerve. This nerve of the thigh emerging from the lateral edge of the psoas major and travel along the surface of the musculus iliacus to the spinal iliaca anterior superior, where it penetrates the abdominal wall and exits just tight because it becomes cutaneous and descends along the lateral surface of the thigh to the knee, innervated with the skill. It's very important nerve. We know that myalgia paresthetica, it's a very common disease to this nerve. And as previous was said, the femoral nerve it's the biggest branch of the lumbar part of the plexus. The initial section is located behind the large lumbar muscle, then comes out from the under. It's a lateral edge. It's located in the furrow between the large lumbar and iliac muscles under the iliac fascia. It follows the muscular lacuna, exciting through the reach to the thigh, and it lies under the fascia, which covers the iliac and iliac muscle, lying in the femoral triangle, lateral to the femoral artery and vein. It divides into terminal branches directly in the muscle, or slightly distal to the ligament. And in this slide, we can see how nerve passes under the ligament and give its branches. On this slide, we can see too. Femoral nerve goes through the adductor canal, as called as Hunter's canal. This canal contains the femoral artery, a vein, and the branches of the femoral nerve, especially and saphenous nerve, and the nerve of the to the vastus medialis. The walls of this canal is musculus arteriosus, musculus adductor longus, and adductor magnus, and the anterior wall is the vastus medialis. The femoral artery with the vein and saphenous nerve enters the canal through the superior foramen. Then the saphenous nerve artery and vein exits through the anterior foramen, passing the vast adductor intramuscular septum. Finally, the femoral artery and vein exit in an inferior foramen, usually called hiatus of this canal, through the inferior space between the oblique and medial heads of adductor magnus. It's a common site of compression of the saphenous nerve. You should know about it. The motor branches of the femoral nerve are branches to the all heads of quadriceps femoris, and also to musculus arteriosus, tenuous, and its muscles flex of the hip and extends of the knee. And also femoral nerve have a sensory branches. So the distal branch of this nerve is a saphenous nerve. These nerves innervate the skin of the anterior medial thigh and medial aspect of the knee, leg, and foot. Then another big nerve is a obturator nerve. This nerve passes through the obturator canal to the thigh, and it innervates the muscle, obturator externus muscle. It also innervates hip joint and all adductors muscles, along with 𝐬𝐻𝐳, pequeños, as well as the skin and body. And these nerves go through his obturator canal. This canal is furrow on the lower surface of the pubic bone, bounded from the below the obturator membrane, and muscles attached along its edges. The external opening of the obturator canal is projected 1.5 centimeters downwards from the inguinal ligament and 2 centimeters outwards from the pubic tubercle. There's a deep opening of this canal is directed in the space of the small pelvis. The external opening of the this channel is located on the upper edge of the external locking muscle. And also obturator nerve have the anterior and posterior branches, which are innervates the all adductors muscles, as well as this nerve has a sensory function. This nerve innervates the medial surface of the thigh. The next nerve, what I want to talk about it is the pudendal nerve. This nerve leaves the pelvic cavity through the foramen piriformis, but it not descends into gluteal region along the sciatic nerve. This nerve bends around the sciatic spine from back to front, passing laterally to sacrospinous ligament, and enters the sciatic rectal fossa. This nerve enters the sciatic rectal fossa through the small sciatic foramen. In the lateral wall of the sciatic rectal fossa, this nerve in its capilline internal genital vessels pass through the canal, which called pudendal or 𝐿 canal. There can be the site of the compression of this nerve and the site of the neuropathy of the pudendal nerve. Then on immediately after exiting the pudendal canal, the nerve divides into 3 terminal branches: the inferior rectal nerve, the perineal nerve, and the dorsal nerve of the penis and clitoris. And the largest nerve of the entire body, sciatic nerve. Sciatic nerve is direct extension of the sacral plexus containing the fibers of all its roots after exiting the pelvic cavity through the large sciatic foramen below the musculus piriformis and under the gluteus maximus, where this muscle is covered all this area. Further down, the nerve comes out from the under the lower edge of musculus piriformis and descends vertically on the back of the thigh under the flexors of the shin. It gives starts to muscle to the ramus muscularis, to the posterior muscle of the thigh. It gives branches to the musculus semitendinosus, semimembranosus, and to the long head of the biceps femoris, as well as the posterior part of adductor magnus, the short head of the musculus biceps. This is a branch from the femoral nerve. From here, the branch goes to the knee joint. And in the upper part of the popliteal fossa, it divides to the two main branches. The medial branch, the thickest branch, it's nervus tibialis, and the lateral branch, nervus peroneus communis. Quite often, the nerve is divided into two separate trunks already along the entire length of the thigh. Now, the common fibular or peroneal nerve runs laterally from the to the nervus tibialis to the head of the tibula, that piecing the beginning of the muscle peroneus longus and divides into two branches, deep and superficial. On its way, this nerve gives branch cutaneous sura lateralis, which innervates the skin of the lateral side of the shin. Below the last one, nervus cutaneous sura lateralis connects with the nervus cutaneous sura medialis, and it's forming nervus suralis, which wraps around the back with a radial angle, giving branches to the skin of the heel, and then goes under the name cutaneous dorsalis lateralis, the lateral edge of the foot, supplying the skin of this edge and the lateral side and little finger. The superficial branch of the fibular nerve descends between muscles into canalis muscular peroneus superior and giving them muscular branches. At the border of the middle and lower third of the tibia, it penetrates the fascia only cutaneous nerve and descends to the middle descends the middle of the back of the foot, dividing into distal branches. And one of them, nervus cutaneous dorsalis medialis, innervates the medial side of the thumb and edges of the second and third fingers. The other branch, cutaneous dorsalis intermedius, is divided into nervus digitalis pedis, innervating the side of the dorsal surface of the second to 5 fingers facing each other. On this slide, we can see the area of the which one innervates by the superficial branch of fibular nerve. And the second one is the deep branch. The deep branch runs accompanied by arteria tibialis anterior, gives branches to the musculus tibialis anterior, extensor digitorum longus and extensor hallucis longus, as well as ramus articularis to the ankle joint. Nervus perennius profundus along them with a combined artery extends to the real and innervates the short extender of the fingers, and then dividing into nervus dentalis dorsalis, supplying the small area of the skin between first and second fingers. We can see this small area on this slide. And deep branch of the perineal nerve goes under the retinaculum. Extends in this area. We can usually see the second place where nervus perennius can be where we can see a neuropathy of this. Yeah. And the largest branch of sciatic nerve is the tibial nerve. Tibial nerve goes straight down in the middle of the popliteal fossa along the path of the popliteal vessels, then enter the canalis popliteus and combine artery and veins. Tibialis reach the medial ankle. In the popliteal fossa, this nerve gives muscular branches to the musculus gastrocnemius, plantaris, soleus, and musculus popliteus, as well as several branches to the knee joint. In addition, there's in the fossa, popliteal fossa, the tibial nerve gives off a long cutaneous branch, nervus cutaneus suramedialis, which goes down along the vena saphenna parva and nervates the skin of the posterior medial surface of the shin. And the tibial nerve goes on the side of compression. It's retinaculum extensorum, and after that, tibial nerve divides into plantar nerves. The medial plantar nerve, together with the artery of the same name, passes into sulcus plantaris medialis on the medial margin of the musculus flexor digitorum brevis and supplies this muscle and muscle of the medial group with expression of the musculus adductor hallucis and the lateral head of the musculus flexor hallucis brevis. Then the nerve eventually splits into 7 nervus dentalis plantaris, which one goes on the medial edge of the thumb and along the way also supplies the first and the second musculus lumbricalis, and then the other 6 nerve skin of the side of the fingers facing each other, starting from the lateral side of the thumb and ending with the medial edge of the first nerve. And nervus plantaris lateralis, the lateral branch of the tibial nerve, runs along the artery in the sulcus plantaris lateralis and innervates all 3 muscles of the lateral group and musculus quadratus plantaris through ramia muscularis, and is divided into 2 branch is deep and superficial. Ramus profundus goes along the misplantar artery arch and supplies the third and fourth musculus lumbricaris and all musculus interossei, as well as musculus adductor hallucis and the lateral head of the musculus flexor hallucis brevis. And the superficial branch, ramus superficialis, gives branches to the skin of the sole and divides into 3 nervus digitalis plantaris proprii, extending to both sides of the two. The side of the fourth finger facing the other. And that's all. Thank you very much for your attention.
Yeah, thank you very much for wonderful talk from both Sevline and Egor. I think both provide comprehensive overview for the nerve from the lumbosacral plexus. So this is an anatomy course. So Deborah, can I speak about my, if I can give example about clinical case? Hello, Deborah, are you still with us?
Yeah,
Hello?
sure. Just go ahead.
Yeah, just like I agree with Sevline that she mentioned that sometimes spine surgery cannot separate from peripheral nerve surgery because there is sometimes in some cases some kind of intersection, intermingle between this kind of practice. Let's say I have a patient with quite young patient. He's kind of injured at the flank, and then after that he have the groin pain. So in this case, what he was diagnosed, groin pain. Another patient was diagnosed as hernia. So he has done kind of herniorrhaphy. So if you don't know this nerve, you can guess after the herniorrhaphy, the pain is getting worse. So if you don't know this nerve, you cannot diagnose. You can diagnose groin pain as something else, hernia, joint pain, L1, L2 injury, L1, L2 herniated disc like that. So it's kind of so actually I performed the tap block. So the nerve line in between the external oblique, if you can remember, there are 3 walls of the abdomen: external oblique, internal oblique, and the transversus abdominis. The iliohypogastric and the ilioinguinal nerve would lie in the plane between internal oblique and the transversus abdominis in the flank. So if you have injury at that level, of course, the patient can present with groin pain. So I do the tap block, the pain is getting better. So to emphasize the anatomy is that if you don't know this kind of small nerve, you have tendency to miss some kind of diagnosis. So for this kind of the knowledge of peripheral nerve anatomy can give us on diagnosis. And another one is that when the patient have the spine surgery and when they lie the patient in the prone position for such a long time, sometimes the patient wake up with groin pain, with lateral thigh pain. So this knowledge of innervation of the ilioinguinal, iliohypogastric, and the lateral femoral nerve, you have to separate from each nerve from the presentation. So yes, sometimes the patient have in the prone position for a long time, you can have this kind of compressive symptom from this nerve. It is kind of for clinical example.
I have to say thank you for these remarks, and I also would like to remember what Dr. Sevline Estehtia started when she was about to give her own presentation. She said that, yes, it's true what Professor 𝐧𝐞𝐫𝐢𝐻 said, that she's doing a lot of spine surgery, but she said that one of the reasons why she has started to approach peripheral nerve surgery is exactly because it's essential in differential diagnosis. And this is something that I would like to highlight and emphasize as much as possible. Peripheral nerve surgery is something that should be in the hands of neurosurgeons, at least in terms of the theoretical knowledge, because it's essential in the differential diagnosis. I think all of us doing peripheral nerve surgery have done a lot of cases of patients that were misdiagnosed and given indication for surgery, for spinal surgery, but in reality, they had issues related to, for instance, thoracic outlet syndrome or other problems. So again, it's very important. If my friend Lucas is online, and I see that he is online, of course, he would never disappoint me. I'd like him to say a few words because, as I mentioned at the beginning, these webinars are also a way to introduce new colleagues who have started to appreciate peripheral nerve surgery. I already mentioned that Bulat and Egor are new joiners in the circle, and that I really appreciated their incredible expertise and job when I was in Siberia in February. But I think Lucas, who knows the situation better than I do, probably would highlight a little bit better the great work that they do there. Lucas, would you say a few words, please, for us?
Yes, I will. It was a great time in Novosibirsk. It was a fantastic theoretical hands-on on cadavers and live surgery organized 3-day event, which was well attended, and high quality of presentations and interactive learning was delivered there. So Novosibirsk Federal Neurosurgical Center in Novosibirsk are constantly working on peripheral nerve surgery and improving the quality of service providing to their patient. We operated 10 patients that in one day related to the different peripheral nerve system disorders, and it was fantastic experience. I am absolutely convinced that Bulat and Egor and the other guys from Novosibirsk, headed by 𝐬𝐻𝐫𝐻𝐸, will continue to develop peripheral nerve surgery in Novosibirsk in a best possible way, like they did so far. Generally speaking, this is something which is very important worldwide, and in terms of small group of devoted neurosurgeons who are dedicate their lives in terms of providing best educational service and treating the patient with different peripheral nerve surgical patients with different peripheral nerve system disorders. This webinar is of outstanding importance, and we discussed that many times before, and my congratulations to all who organized this. To add a little bit more on the top of all this, we have now today possibility to see something what is so called advanced education on simulators, which
Yes.
our dear friend Federico will provide. Federico will come in Belgrade in 2 days, so we have a pre-congress upsurgeon meeting on the other topic. Topic is pediatric neurosurgery craniosynostosis. But generally speaking, this is something which is of outstanding importance in contemporary learning of neurosurgery in general. But I am very happy that Federico is now moving on one step beyond the limits and now focusing also on peripheral neurosurgery. So this is something which I'm very happy, and I'm sure that you will enjoy to see how these things are working. And Federico, I'm looking forward to welcome you in Belgrade in a few days in Novi Sad.
Thank you so much.
And of course, you all have invitation to come in my department and to join for our renal communications. But For this time, our renal communication is starting in 2 days, but for the next year, we will also be invited. We'll have a special session regarding peripheral nerve surgery, oncology. So this will be also a great opportunity for the education in this manner. So I will leave you now in Deborah's hand and Eckhart also to guide the seminar webinar until the end. And enjoy in this presentation what Federico you will now provide. And after that, to fulfill the quiz, and who is the best, he will receive the award. Okay.
Thank you, Lucas. So
Congratulations.
thank you so much. I thank you so much because you already also started to introduce the great work done by Dr. Federico Nicolosi. I have to say that I think he's actually already well known around the world, so introductions are probably superfluous, but in this webinar, so last time and this time, we're also trying to provide information for participants on how to improve their skills and their knowledge. So last time we had Professor Thomas Piriev talking about the great work he's doing with his three-dimensional neurosurgical atlas. And this time we have Professor Federico Nicolosi, who's going to give an amazing presentation about the incredible work that they are doing. And I'm sure that everybody who doesn't know will probably immediately try to, get a subscription to the upsurgeon courses and everything, because it's a new door for education. It's the new way that education is going to be provided in the future. So Federico, please, if you want to share your presentation and start. Thanks so much.
Thank you so much for the incredible introduction. Professor 𝐏𝐞𝐫𝐢𝐻, it's a great honor to be here. And thank you, Professor 𝐬𝐮, for your words of friendship. I'm really, first of all, I need to say thank you because I am, let's say, overwhelmed by all this consideration. Thank you for giving me space today. I will share my screen now. So please tell me if you see my presentation. You see the screen?
Yes. We saw your presentation.
Okay,
we saw your slide.
Thank you to you all, also to Professor Ghitpun and all the other speakers. My topic will be more general and transversal, so I won't talk about peripheral nerves. It's not my surgery. I'm a neurosurgeon, and my topic is mostly cranial surgery. And today I will talk about how technology is changing our way to do surgery. This picture is just the AI generated picture, just to say how it will be in the future. We still don't know, but the point is we are deciding what will be the future. The great thing that I find interesting is that between a discipline and another, sometimes we discover great difference, incredible difference. For example, in some discipline, we are already using robotics. I do an example in neurology, urology, or general surgery. We use robotics in a way that we still cannot even imagine in cranial surgery or in peripheral nerve surgery. And that's why we need to, let's say, merge, sometimes create bridges with the other disciplines, because what we think innovative is already done in other disciplines. And the problem that we know is that today, with the technology, we are 21st century, but the way we transfer the skills is still the same as 1 century ago. And the point is that we still practice directly on patients and cadavers, and this is a problem. But the point is that thanks to the innovation and thanks to key opinion leaders that have a great vision, we are changing the way. In other words, like in this example of Professor Spetzler, we are moving from a circumstantial practice or a randomic practice to an intentional practice. Using simulation, we can decide how many procedures that a resident has to do by the end of the career or by the end of the year, and we can decide the right timing to learn. And there is a timing to learn, and this is nothing related with surgery. This is something already been studied in many other disciplines. If we do sport or music or whatever, there is a way to learn, and it's a spaced repetition learning, and we cannot do this on patients because if you consider the same residents of the same school, they will have completely different masters, situations, days, or rotations in specific centers. So the point is, if you take 10 residents from the same school at the end of the cycle, they will be completely different one from another because the training is a bit randomic. So we need to be able to merge this and mix this with simulation, not to replace cadavers, of course, but to integrate. Because, for example, I remember my first experience and first-year resident. I was a first-year resident, first time on a cadaver. I did for the first time a pterygium approach. I was convinced that that was absolutely a good learning. And after 3 months, I was in the operating room for the first time. And I said, okay, I did this 3 months ago on a cadaver. I will try on a patient. It was a disaster because I needed training between that experience and the real case. This is pictures from our cases. My great love is the skull base or posterior fossa in particular. And when we talk about this kind of surgeries, you cannot take for granted the training because it's so difficult to do the intradural training on this kind of situations. But I want to share with you that the training is all related also to microsurgical skills. I were talking about mental skills, manual skills. This is an example of a micro dissection of arachnoid, so nothing related with peripheral nerves, but just to say these skills is the same skills that we need to learn for peripheral nerve. No one can learn this on the real world, let's say the macroscopic world. And this is an example. This is a micro dissection of an arachnoid for an aneurysm, so for the clipping on an aneurysm. And suddenly it can happen something that you are not prepared. So the rupture of an aneurysm is a moment where no one can be trained on this. So what you do, how do we train people on this kind of situation? And we can say, I made a mistake, I'll try again. But in this situation, it's like saying there's a disaster and the pilot come back there and say, okay, I will try again. Sometimes you cannot because you cannot try again because sometimes this situation can paralyze a young resident. So you need to be also emotionally prepared to manage your errors. And there is a fear now in our discipline. High-risk disciplines are, let's say, situations where many are, let's say, stepping back because there's a lack of training. And the other thing is that we are very prepared on one side, but the tools are incomplete and very randomic. So in other words, we need simulation to fill the gap. And I will make here a few examples of there is a lot of virtual simulation, a lot of simulation on real tissue, but the accessibility is not always perfect, or also animals. And this is an example on a microsurgical dissection on an animal. So this is a living animal. So to do a microsurgery on a small vessel, we need to sacrifice a rat. And this is actually how we do. But what we think is that there are many other ways to do this in many disciplines. And the technology is changing disciplines. All of what you see here is the combination of simulation on one side and advanced parameters, analysis of skill parameters. So how do we measure a surgeon? This is the problem. There's no objective metric. If you look at me, I am a colleague of you, but there's no way to measure myself. There's no way to measure yourself or to see how your learning curve is changing during the time. So the point is that the day that someone will be able to identify objective metrics, many things will change. And this is actually the goal of measuring, even if surgery is not a competition, but we don't want to measure surgeons. But how do we understand what is a better procedure if we all do practice on different fields? So the field is in this case the ground where we do a race with cars. Obviously is a metaphoric image, but want to say is there's no competition, but somehow we need to measure something. And this is an example of an important study we did with Harvard a couple of years ago. This is a simulation we created, and Harvard started creating spaced repetition and analysis of the performance with scoring. So there was a blinded observers that started analyzing the performances, and we started measuring the training of residents who did the training and residents who didn't. And this is another example of an important study we did with Harvard and Stanford, where we did the same on spine surgery. And the point is, what this resident is doing is not in a lab. This was a random room at the university, and they were trying to simulate step by step an anterior cervical dissection. You know, is a procedure which is quite regular in neurosurgery, but this is quite scary if you think that there is a moment that you need to be trained enough to feel and dissect and lateralize the carotid. And so, of course, again, this is not peripheral nerve surgery, but it's just an example to say we need even a tissue pulsating to give you the right sensation of what you are doing. But what I will show is something related now to peripheral nerve. We started doing advanced training also. This is an example on a finger dissection where we want to teach any step of a dissection and also the step of the dissection of any structure inside. So inside we need to be able to identify all the structures of in micro dissection or micro dissection. I will show you a better video where we have the tendon, bone, arteries, and nerves, and you need to be able to do all the steps of the dissection, and then at some point identify all the structures. Of course, I won't add anything to the surgical nuances that have been discussed by my colleagues before. This is just an example of how simulation can be reproducible and sustainable. And in this case, there was a finger dissection. So plastic surgeons and orthopedics together did a course where we had both the soft tissue management, but also the hard tissue management with the fracture of the bone. So we need to identify, in this specific case, the goal was to identify the artery and to do even a micro anastomosis. So in this case, one of the arteries was identified and dissected. So also the dissection is an important skill. This is Professor 𝐬𝐬𝐲𝐶, a great friend of mine, plastic surgeon, who was performing this micro dissection. So he's also a cross section of disciplines. You know, we work with also other specialists in this case. And the goal was to do a microanastomosis, so it was microvascular. Obviously, we are now destroying the artery. This was the nerve, of course, and I will show you the nerve, and we are working on a special structures for the nerve, but there was also the artery, where I want to share with you also the vascular steps of the surgery, where we did the exercise, so all the step by step. And then at the end, even the patency test to see if the quality of the suture. So this kind of situation could be done on a desk, exactly on the desk where you are now today for this presentation. That's where we open possibilities. Of course, there are a lot of technologies for simulation, and these are mentioning other technologies, but the point is the culture that is changing. So we need to be open to the technology. But this is fantastic, but these are toys. We need to measure performances. So how to measure performances started from surgery and started from simulation. And I will share with you a series of studies of sensorizations or haptics related to the measure. So in other points, the point is, what are the parameters of the talent or the growth of a surgeon? So in this case, we have a group that sensorized even surgical instruments to understand how we move or how we open and close an instrument. And generally, all these parameters are a lot of data that we simply don't know how to use. So many studies, the literature is full of many studies where we measure parameters, but we need to understand even gloves with sensors. We need to understand if these parameters have specific meaning, because without a meaning, these are just data with no sense. And we did something, again, coming back to the cranial. We started sensorizing simulators. This is an example of a cranial simulator where we manipulate the brain and we start having parameters of, in this case, the force on the brain, or even the optic nerve or other structure, where we try to understand what happens inside. And we did a study, and what was very interesting to see, this is the logic of the construction of the technology and how we manage the data. And the study was based on a data collection contraction of the hands during the exercise, and also a series of other data, the forces, even the emotional impact of the resident during the training, and understanding how the emotional impact changes, or better, how the complication has an emotional impact. And from this study, we had an incredible impact that at the end was the system was able to demonstrate the difference between a resident and an expert surgeon. And the same system was able to identify the best resident and the worst resident. Sorry if I say best and worst, but in the exercise. And this was very good or very bad. You can take your position in a classification and like a push on your motivation to train more, to do more, and to do better. So that's the point. We don't want to classify things forever. We want to just do a picture of today, you today, and yourself compared to your skills of today in 1 year after training, after cases. That's the point. We can be the control of ourselves. And if I use the same environment, the same case, the same complication, I can measure myself and I can see how I change during the time. This is the goal in general of the advanced simulation that we are trying to build. And of course, this is a final message is we don't need to reinvent the wheel anytime. There are so many colleagues around the globe working on the same things. And the point is many times to connect with them, with other disciplines, and try to understand how to accelerate the change of the culture. Thank you so much. And I'm open to receive any question from you. Thank you.
Federico, thank you so much. As I expected, this has been an amazing talk, especially because it opens a door to the future. And I appreciate it very much that you mentioned that this is not supposed to replace cadavers. This is not something that should replace cadavers, because that's important as well. But it's something that should be integrated. It's another option, another possibility that we have. I think we previously discussed how important this could be, for instance, to improve education in low and middle income countries. And actually, I have to thank you, because you also do a lot of efforts to help the young residents and the young neurosurgeons in those countries, providing courses for free. So you really have a commitment to education and also to the development of global neurosurgery. So it was actually our pleasure and our immense honor to have you here. And well, we do hope that we are going to catch up face to face soon. And of course, we have started a collaboration already some time ago to try to develop also simulation for peripheral nerves. And I think we have to progress about that. So we'll keep in touch, and maybe next year we can show another amazing talk, but on just on peripheral nerves.
Absolutely. Thank you so much, Professor Ghehret. Thank you to you all.
Thank you. I think Lucas wants to comment. So Lucas, please tell us what you wanted to add.
Federico, I know everything about this that you presented, and I enjoy every time when we are doing these things together. I do believe that you will improve these upsurgeon models for peripheral nerve surgery, which is also important for us. And this is something which is a future. This is a future in terms of education, in terms of having a simulation, different type of simulators and models, which can give us possibility to train in the same time while we are not in the situation to use cadavers, because cadavers, we cannot use cadavers so frequently. And this is something which have to have the place in the education in all fields of neurosurgery. Now we are talking about peripheral neurosurgery. And congratulations once again. Looking forward to welcome you in 2 days in Belgrade, in Novi Sad. And then at the end, I would like to express my gratitude to Professor 𝐏𝐿 𝐸𝐻𝐻 for her visionary ideas in terms of promoting education in all fields of neurosurgery, now particularly in peripheral neurosurgery, and supporting all our actions worldwide in terms of education. And this is something we all have to be thankful to Professor 𝐏𝐿 𝐸𝐻𝐻. And to celebrate this our friendship and camaraderie, which we are evolving for many years. And for many years to come, I'm sure, completely convinced that this will lead to the best possible treatment of our patients and best possible educational possibilities for young neurosurgeons. So, Professor 𝐏𝐞𝐫𝐢𝐩𝐡, I thank you especially for your support to our educational activities of Serbian Neurosurgical Society, and of course worldwide. And of course, we are all on disposal for our mutual work together.
Well, Lucas,
Jake,
thank you very much.
you wanted to...
Sorry. Just a few words to Lucas. Lucas, thank you very much for the long-lasting and your the educational motivation, and also that you did a lot of things. And we have so many neurosurgeons, more than 12,000 neurosurgeons in Japan. So I think they do not know how fantastic of to learn the peripheral nerve. I think maybe sometimes we can collaborate the Japanese or Asian doctors with their committee, this committee, I think, Deborah. Maybe future, please. You can make some.
Yes, we are available. We are absolutely delighted. Actually, 2 Japanese surgeons are in our committee, and they will be online to share and to talk also in the next webinars. So we can expand our interaction, and we can expand our connections with Japan as well. That's also one of the reasons why we have a peripheral nerve surgery committee, and in ACNS, of course, Japan is a country that has to be included. So thanks so much.
I do believe.
Please go ahead.
Oh no, you go ahead. You go ahead, please.
No, just I want to say one word to Dr. Federico. Your presentation was amazing, I think. So from the anatomical aspect to the AI, or the recent 3D model, I think it's very, very important, especially for the younger generation. They need such a model, I think. So that is very ideal, fantastic, your presentation. Thank you so much.
Thank you so much.
Thanks,
Let me thank you also to you, Professor 𝐏𝐞𝐫, because this series is now very long and it's fantastic and amazing. So thank you to the organization and for you to share this. Thank you to Professor Rasulic for what he said about what we are doing together. Last year we did an incredible course together in intraventricular surgery, and this year another incredible course with 10 stations with children with cranial malformations operated. And I want to thank you, Professor Garozzo, for chairing this session. I want to say technology is nothing without visionary leaders like you that indicate the direction. We are all, let's say, in this world trying to understand what is the right direction, and your indications are what we follow. Technology is just technology. Without your vision, nothing could be possible. It sounds like a bit romantic, but actually this is what I believe personally. So thank you so much.
I do believe that all neurosurgeons from Asia, particularly Japanese neurosurgeons, will understand the possibility for this education in this field, and we are more than eager to welcome them to join us in every manner. You understand me? So this is especially for the Japanese. You know that I'm, I would say, Japanese guy, and I would say Japanese orientated in a state of mind, in a mentality. So this is something which is my great pleasure if I can welcome any of Japanese colleagues, neurosurgeons in my department, to be my fellows for learning peripheral neurosurgery. That will be, for sure, great experience and a great opportunity for them to learn, and a great opportunity to strengthen our relationship.
Thank you.
Great. I think I'm sorry to say that, but we also have to proceed with the test. We have the quiz now. So Federico, thanks again for your amazing presentation, and we do hope that we are going to host you many times in the future as well. A big, enormous thank you to Professor 𝐏𝐿 Anisimov, because without your support, we wouldn't be here to run this course. And thanks to my friends Jitpun and Razulic for being here to share with me. But we have now to do the quiz, because as you know, this is an online course that requires the participants to take a quiz, and we have the three speakers, �𝐾𝐫𝐢𝐩𝐡𝐞𝐫𝐚𝐺 and Anisimov and Estehtia, who are going to run the quiz. So if Professor Raja is online, and we can start. So all the participants.
So may I launch the quiz?
Yes.
Okay. So the quiz is on. Everyone can start answering. Can you see the quiz?
I can see the quiz,
Yes.
so I assume everybody can see that.
Yeah, go ahead. We have can give 5 minutes.
So I think the first questions are for Dr. Sevline and for Dr. Egor, and the ones about the brachial plexus should be afterwards, right? So
request everyone else to join the quiz and
so
start.
are all the participants online for the quiz? Of course, the panels are not supposed to take the quiz, and they are not supposed to suggest the answers to the participants. So Sevline, would you like to start reading the first questions?
The first question is, which of the following muscles is an internal rotator of the thigh? A. Piriformis, B. Obturator internus, C. Quadratus femoris, D. Gluteus minimus, E. Gluteus maximus.
Professor Raja, you tell us when we can proceed with the next question.
Yeah, go ahead. Go. The quiz is open till 5 minutes. We can just go ahead, question each one by one. Okay. 8 minutes is sufficient, I think.
Should I continue to the number 2, Professor Garza, or?
So you just read the questions related to your talk, and then we'll have Bulat and Egor to take on when it's related to their questions.
Okay. Number 2, after an injury, a patient is able to dorsiflex and invert his foot, but is unable to evert his foot. The most likely nerve lesion is the A, deep peroneal nerve, B, superficial peroneal nerve, C, common peroneal nerve, D, sciatic nerve, E, tibial nerve. And number 3, the lumbosacral trunk is formed by which of the following nerve roots? A, L3 and 4, B, L4 and 5, C, L5 and S1, D, L2 and L3, E, S1 and S2. And the fourth question, which of the following nerve originates from the posterior deficiency of the lumbosacral plexus? A, obturator nerve, B, tibial nerve, C, pudendal nerve, D, femoral nerve, E, nerve 2, quadratus femoris. And the last question from my topic, the tibial component of the sciatic nerve supplies which of the following muscles? A, short head of bicep femoris, B, gluteus maximus, C, semitendinosus, D, sartorius, and E, rectus femoris. So that was all my questions, Professor.
Okay, so is this enough time for the participants to reply?
Only 19 people have, 20 now have participated. We are expecting more.
Well, we have 149 participants online, so 20 is really very short.
Yeah, the numbers are rising slowly.
Okay. We also have the questions about the brachial plexus, right?
I have received 8 questions total. Oh, you mean the part 1?
Yes, we also have the questions from part 1.
Part 1. Okay, let's finish with this one first.
Yeah, because we have Dr. Bulat who's here because he was the speaker of part 1. So,
right, as you said, this is an experiment in the beginning.
Well, you know,
but it's working
we are
out
trying.
fine.
We are making something new. So, of course, like every time you try something new, there is a period of adjustment and a learning curve. But in the meantime, that doesn't mean that the participants are not supposed to give their answer. So how many participants have replied now?
58.
Is 42% of the
60,
participants.
63. 65.
It's getting more and more.
Yeah, 51%.
So
we can just close it in 2 minutes. That will be 10 minutes time. Okay. I hope you are not answering the quiz, Deborah. Okay, 1 more minute and we're done. So around 60% have participated now. $65. Okay, it's time, so I'll end the poll.
Good.
Okay, so 69% participated, and I'll just share the results.
Sevline,
Okay.
you are please going to correct and
So the
announce
answers are there already on the screen.
Okay, sorry.
Which is ticked in green. Okay. So for the first question, 62% of the people answered correctly. That is good. For the second question, 59% of the people answered correctly. For the third, again 69% answered correctly. For the fourth, 65% answered correctly. For the fifth, 53%. For the sixth, 71%. For the seventh, 71%. And for the eighth, 60% answered correctly. So I think it's wonderful. I think most of them have got it right. Okay.
Good.
So thank you very much. I'll just check for the first where I have uploaded the surveys. No, it opens
So
another.
we have the second group of questions for Dr. Egor, right?
Yes, it is, but loaded under the surveys. It opens another. I think it should open in the after the Zoom meeting is over. It may open for the participants. I didn't know actually what the setting was, so we'll let it go for this time, I think. Is that okay?
Okay, and what about, so we do not have the questions for the brachial plexus as well, right?
No, it should open after the Zoom meeting closes, I think. It will open another window in the browser of the participant.
Okay, so what are we supposed to do? We just leave and then we
Yeah, once you end, it should open another window. That was the setting, but I'm not sure how much of it would work. We'll try again next time in the same pattern in the next webinar, I think. Is that okay?
Well, if we have some technical difficulties, at least we had a little bit of questions.
Okay.
Then I think we could just start wrapping up, but I would like to invite Dr. Bulat Kindziagulov and Dr. Egor to give the final remarks, as we had them silently. Well, Egor was not that silent. He actually spoke quite a while. But yes, because they are the ones who completed the webinars on anatomy. So I would like maybe starting with Bulat first and then with Egor. Can you just give us a few words?
Hello everyone, once again. Everyone. It was second seminar, webinar, and it was perfect as always. Thanks for organizers. It's really interesting part. The sacral plexus is very hard to imagine for us. There's many issues, many problems that we faced in clinics. It is related to the upper extremity for the most, but you should always remember that lower extremity is very important too. You should always remember the anatomy of the lumbosacral region and plexus. For the quiz for brachial plexus, let's meet on the third webinar. Review the brachial plexus anatomy once again.
Yeah. So this means that you are going to be on board next time as well. And the same thing applies to you, please, Egor. Egor, can you just... Thanks so much. Egor, can you say us a few more words?
Yeah, thank you so much. I really appreciate having a chance to speak about the upper extremity and about the nerves of the lower extremity. Anatomy is the essentials of everything we doing in operation room, and not only in operation room, but also what help us to understand what was happening with the patient. And thank you so much for these webinars. I think they two of them was really good, and we will see what we will get in the next webinars. Thank you so much.
Great. Ika, can you please just close? Would you mind to do that?
Just a little bit of my word. For the new learner, I guess a lot of audience here are new learners, newcomer for peripheral nerve surgery. I know that this remembering and learning all the anatomy of the brachial plexus and 𝐬𝐻 branch and the lumbosacral plexus and 𝐬𝐻 branch take a lot of energy, take a lot of time, and this might seem difficult at first when you start learning it. But yes, I think it takes time, and it takes a lot of exposure in the peripheral nerve surgery to take you get used to this kind of anatomical pattern and variation. So keep on learning. I would like to support of you guys for the learning of the anatomy.
Great. Okay, so then I will say just a few more words and then we close it. I think this was our second webinar for this online course, and so far I would say that we are very satisfied with the interest and the participation that we have. So a few more words. There are people that are overwhelming Professor Raja, myself, and also Professor Boone with questions related to the modality of the course. So I'm going to repeat first and all. There is a program, and this program has been already forwarded to all the participants. We of course send reminders of the webinar a few days before each webinar takes place, but it is also a responsibility of the participants to check the calendar and be ready and take their time off when they need to attend the webinars. I'm sorry to say that, but we are all here neurosurgeons. Everybody is very busy, and of course it's our own duty to organize our time. It is very clear that the online course is going to give the diploma only if the participants will attend 70% of the webinars. And if you miss it, you can anyway go on the YouTube ACNS channel and follow up again. So 70% of active participation is necessary. Once we access the webinar, you are supposed to be there, because if you just leave it, you cannot access it any longer, because we don't want people to join just for a few minutes trying to prove that they have attended when they in reality they have not done. Taking the quiz whenever it's included in the webinars is compulsory, and at the end of this online course there's going to be a face-to-face exam which is going to be online, that will be done with me. So it's not only a multiple choice quiz, but there is something else. You have to prove me that you really developed a sound and comprehensive knowledge of peripheral nerve surgery. Having said that, I would remind that Professor Raja graciously drafted all the rules, and they are also in a link which has been forwarded. And then just let me say thank you for all the speakers, because without you, of course, we wouldn't be able to do the course. Thank you to the ACNS for providing us the platform. Thank you to Professor Raja, and by the way, happy Diwali to everyone from India, because I know that this, this webinar was probably, to be squeezed in family celebrations and everything, and of course, just go on doing a good work, and we are going to catch up again in 3 weeks. And that's going to be with diagnostic assessment. So we are going to talk about electrodiagnostic test, and we are going to talk about imaging. So I think we can say goodbye, close, and go back to clinical work.
Yeah, we'll take final concluding remarks from Prof. 𝐏𝐞𝐫𝐢𝐻𝐡 before we close.
Yes,
no, it's fine. It's okay. I already talked.
Okay,
so, but I think maybe in the future, maybe we want to see the surgery maybe the collaboration with the anatomy, with surgery. So maybe step by step. Thank you very much.
Congratulations to everybody, to speakers, to organizers, and great atmosphere. Bulat, I'm also waiting for you in Belgrade in next few days, and during your stay in Belgrade. So we are more than active. So that's very good.
Right. Thank you very much. So there are so many questions that people are asking where to find the webinars which are archived. So I'll just let you know how to search for them. I hope you all can see this. Okay. So thank you very much. I hope it clears it. So we'll close this session now. Thank you very much, everybody. Bye-bye. See you.
Bye.
Thank you so much.
Thank you so much.